All right, everybody. Well, welcome and thank you for joining us today on Benovate Explores. This is Benovate's monthly webinar conversation on health, risk, and insurance in an ever-evolving industry. My name is Alex Sarah, and I am the Director of Client Services here at Benovate. Oftentimes, when I'm working with our clients, they're giving thought to the ways they can build upon their existing programs. And the conversation turns toward how to gather, understand, and use data in a more effective way. Oftentimes, there's a lot of frustration and even skepticism around the topic of data, either because people don't understand it, don't trust it, or simply just aren't aware of what's possible when you have the right tools and the right expertise. So with that in mind today, we're going to meet our guest presenter and continue the conversation we started back in January. And then we'll have plenty of time at the end for some live question and answers with our guests. So stick around to the very end to make sure that you can join into the conversation. All right, let's get started. Now, I'd like to introduce you to today's featured guest, Dave June. He's the lead contract administrator with the National Joint Powers Alliance, or the NJPA. Dave, would you like to introduce yourself?
Sure. Thanks, Alex. Appreciate being here. Hopefully we'll have some insights. I hope you didn't bill me as a subject matter expert, because that just wouldn't be right. But happy to be here and share at least what we've learned in our journey.
Well, great. Thank you so much for joining us, Dave. We're excited to have you. Dave, would you like to maybe spend just a second or two talking kind of about your background and your experience with poor data?
Sure. So I don't know how much the group knows about NJPA, but we're a government agency. We're based in Staples, Minnesota. And in a nutshell, we provide products and services to member agencies. So we serve K-12, higher ed, any form of government, state, local, federal, and nonprofits. And in providing those services, we're always looking to do something that maybe can help our members who don't have the scale or the expertise to do that. So in a nutshell, that's what NJPA does. Now, we have a number of different programming elements to what we do. I work in the contract purchasing area, and the contract purchasing area deals with competitively bid and awarded national contracts. We also have a division that does risk management. I guess that's what we're here to talk about today, correct, Alex?
Absolutely.
So what I was asked to do is leading some of what we do on the competitively bid and solicited side for products and services. They asked for some outside eyes to sort of look at what we're doing in risk management and seeing what if any of those principles could apply to what we do. So on the contract purchasing side, to give you an idea, the scale of what we do, last year, our members bought $2.5 billion of products and services through our contracts. So we have a lot of experience in that area. Our pool is in the low 20s, maybe mid 20s number of groups, right, with about 5,000 lives, and it's self-insured. So that's kind of a nutshell of what our experience is in the risk area. So we were asked to look at that and see, what do we do and what can we do to scale, and how can we do a better job of whatever it is we're trying to do for those 23 groups we serve.
That's great information, Dave. I appreciate you sharing that. Can you tell us a little bit how the lack of data has historically influenced how the NJPA has managed its pool?
Well, how much time do you have? Because I can go on, I can go on and on about that. But let me give you a little background on how I got in the process. Again, I was asked to come in and look at it and said, just a new set of eyes, tell us what you think. So I went to one of our risk management meetings. Our pool, because it's public agencies, is managed by a board of trustees. And I went to one of those trustee meetings. They had them monthly. And I found out that they were getting data from the carrier. And basically what they were looking at is the ECR, our expected claims reserve, right? So we had an independent actuary figure out what our expected claims funding should be on a monthly basis. So they pulled up that number, and let's assume that number is 100 for ease of discussion. And then they pulled up our claims and said, well, our claims were 98 or 106 or whatever it happened to be. And I kind of looked at the group and they said, oh, so the ECR was 100 and our claims were 102. Okay, I guess that ain't bad. Let's have lunch. I mean, literally. And I thought, well, is anybody asking, first of all, do you understand the ECR is just an actuarial guess of claims, right? So we're comparing our experience to the guess, and nobody asked another question. And it sort of dumbfounded me that we wouldn't say, well, if the guess was 100 and the claims were 102, I mean, is that good? Is it bad? Do we know why it was 102? But no one had asked the question. But for years, that's sort of how the pool was managed, because that's what basically the stop loss provider provided to the group. That was it. That's what we had for data, the guess and the result, and then no one seemed to ask why.
So to provide a little bit of context, can you maybe spend just a minute or two kind of talking about what the pool is doing today? And really from their perspective, why you think maybe perhaps that it's still relatively difficult to get good actionable data, kind of even in this era of big data and having all these programs and services that appear to be very helpful.
Sure. So I guess from that point in saying, so we have a guess and we have a number, we then took the next step that says, okay, so our pool happens to be self-insured to 200,000. It became very clear that the carrier was doing a magnificent job of managing the risk where they might be on the hook. So anybody that was at or near 200,000 of claims, they were doing an amazing job, right, managing that. But nobody was minding the store at 200,000 and under. It was just sort of like, okay. So we decided to do our own data pull, to look at the data, to figure out what we had in mind. And maybe a little side story, if I can get off a little bit. At that time, our director had a son-in-law who was a PharmD. And so he'd heard about the cost of pharmacy and all that. And he was absolutely certain that pharmacy was killing us, right? I mean, that was his preconceived notion. So we actually pulled the data on the group. We looked at that data and we said, what can we learn about this other than what the claims are? Do we know where they're coming from and what the population looks like? And as a bit of an anecdote, we found out that pharmacy, in looking at the benchmark data, we were paying at or below benchmark, and our generic use was in the 90s, which is sort of off the chart, and said, if we were going to go to our population and talk to them about pharmacy, no matter what we did, I don't know that we would move the needle. I mean, so what it gave us was a glimpse into the population about what is actionable that we think could actually move the needle for claims, education, awareness, because this preconceived notion about, I'll bet it's pharmacy, was completely flawed. I mean, it was a gut, it was a hunch, and the data allowed us to say, that might be the 15th thing on the list, right? As far as what are the priorities for what our population looks like. Is that kind of what you're looking for from my perspective?
Yeah, absolutely. Absolutely. And having gone through the process yourselves as a pool, I think something that the audience might be interested in kind of hearing from you is, what advice would you give to other pools or employers or even brokers that are looking to help their groups that they work with improve how they approach and manage health, and specifically how they kind of work the system to get access to better data? Is there anything specific to your experience, to the types of employees that the NGPA services, for instance, that you might want to share with the group?
Well, I think what we learned was that the data gives us something, that's actionable and real. If I could be so bold, Alex, we've had this discussion internally with you folks, but one of the things we learned in the broadest terms is wellness doesn't work, right? We had a wellness program and we had people doing various activities and said, if you do these 9 things, we'll give you a $100 gift card. And the guy in the office next to me did those 9 things and said, I'm going to buy scotch and cigars with my $100 gift card. Now, you could argue, I know in overall wellness that might actually help him. But at the end of the day, we were throwing money at a campaign. Telling me to have a mammogram, just isn't necessarily the best thing. So I think what it allowed us to do was target our audience. And I think maybe in the broadest sense, what the data showed us was, when we look at those buckets that you've shared with me, those healthies, those at-risk chronics and acutes, that we had a tremendous amount of our population that was at risk. We had this sort of ticking time bomb that said there's a whole population based on their pharmacy, based on the codes that are in the data for how they're utilizing the system. We had this ticking time bomb. And so to think that, to be lulled into thinking, oh, we have a pretty healthy population or we don't, that snapshot helped us, I think, plan for the future to say, what can we do to be proactive in that whole campaign? And mean, we uncovered some people were using emergency rooms wrong. They weren't using our the EA. I couldn't think of the acronym for it. The EAP plan, right? Our insurance provider of the stop loss has a really nice EAP program that nobody even knew existed and nobody would get to. So I think what this gave us was the ability to sort of, instead of shotgun approach a campaign, kind of like what wellness had been, this broad sort of touchy-feely, hey, if everybody's healthy, our claims will go down. I think this gave us the ability to target individuals and audiences and say, these are the critical factors that are going to lead to a better experience in the pool. Is that, I mean, again, I'm not an insurance guy, but from the outside looking in, it was, how do you communicate with those people who really don't even understand their benefits, what's covered, how to access the system? I mean, don't go to ER, just because, I mean, those kinds of things, I think were very helpful. And rather than somebody's opinion, it was based in fact. So rather than saying, we had to do this on pharmacy, we could point to the data and say, I don't think that's a priority. So I think it helped with the priorities an awful lot.
I think that is a really good point to make, Dave. I think having data to support maybe oftentimes the feeling that people maybe think they know, or sometimes the feeling that they get, that things need to be a certain way. Having data to support that one way or another is a great example of why it's so important to really in making progress towards actual risk mitigation, and also in terms of being able to educate people about the services and benefits that they already have that may just not be utilized to the best of their ability.
Yeah, I think that was really true. Just like I mentioned with pharmacy, I mean, the benchmarking data was really helpful. I mean, okay, we're using generics at this level. That's terrific. I guess we were off the chart. We're close to saying, wow, that's amazing. And what were we paying? We're out here in a rural community. Are we paying way more than we should? Well, the data suggested we aren't. We're paying below that. So I think those kind of things were very helpful, rather than people sort of guessing or trying to anticipate, or, my gut's telling me this is the way it should be. I think the data really helps substantiate those things.
Sure. Well, knowing that you've spent quite a bit of your time interfacing, not just with employer groups that kind of face the same challenges, but also just connecting with people in the industry, I'm curious as to your personal opinions around what you anticipate the market doing in the next few years in terms of making data more available and easier to understand for kind of the broad-based consumer that might understand that it's important to have access and important to act on it, but doesn't necessarily know what to do next with it.
Gosh, that's such a big question. But I think what the future really looks like is, let me talk about our own board of trustees. I don't think they weren't bright people who they're bright, they're well-intentioned, they're trying to do what's right for their group. I think, Alex, they didn't even know what questions to ask. They were told to look at the ECR and the claims, and they said, okay. I mean, if it's close to 100, and now if it's 140, maybe that's a problem. But I think the education, they didn't even know it was available to them. They didn't even know. And so I think to assume that people already have this figured out, I mean, I've had just enough interaction in this space to say, we have people trying to make a decision that have no idea what the variables are, no ideas what the drivers are. I mean, everybody has an opinion, right? Oh, it's the big, nasty hospital. Those doctors are making too much money. Oh, it's there's always somebody to blame for the cost. And I think internally here at NGPA, what we learned is the number one driver of our claims are the individuals themselves. That we've heard sort of generic things like, I know it's group insurance, but every decision's made on an individual basis, right? So it's terribly individual. And again, I think the campaign, the broad brush, anybody who's been in benefits design said, I want $25 office visits because I got 3 little kids. And somebody else says, I just want really a high deductible because I don't use service. I mean, we know all those competing forces. But I think the ability to focus on some data and say, you don't know what you don't know is a great starting point. And the question is, do you believe you can move the needle or don't you? Because I've heard so many people in this space say, well, if I do this, what's the direct ROI? And you say, gosh, I wish there was such a thing, right? I wish there was. So I don't know if that answers it or not, but I think the learning curve in saying, what does the information tell us? And if it doesn't tell us anything, fine. And if it leads us in a direction, we say, what do we think we can do? Because the whole idea is to beat the trend, right? The whole idea is to say, if we know medical trends going like, now it's going to sound like I actually know what I'm talking about and you know better. But trying to beat trend and saying, how do we reduce that? How do we educate people? How do they access the system? I think sometimes we get a little too far in the weeds instead of that basic. Do they even know how to get into the system? Do they really have a primary care physician? Do they really even know how their coverage works? Do they even know what they're getting? You know, I mean, oh, my prescriptions are free. Well, they're not free, right? They have a cost. But I think sometimes people in the industry are so knowledgeable they miss sort of the Captain Obvious part, which is engaging that population. And if you don't engage the population, I mean, good luck, right?
That's the first and last stop there. Absolutely. And I think we would definitely agree with you, in terms of being able to capture that data and put it to use in a way that makes sense for the end user, right? Because you can't have any real impact unless we can eventually do things like incentivize the users of the programs to make real progress towards actual change in the way they use their benefits, they access care, and really engage in their own health and well-being. So actually taking kind of a look here at the next slide, the shot will show you kind of one of the live reports, for instance, in our Benovate admin console. And Dave, I think you've seen this from time to time, but the shot will show the different risks that members of the population have been tagged with. And this report, when shown live, shows kind of up to the minute data. And really imagining the difference between seeing that risk information year after year, just one time a year, or really never in some cases, versus being able to see it live and then going back to the board, going back to the people that are the benefits decision makers and saying, we're starting to see a trend here. Rather than waiting 8, 10, 12 months down the road and then making a snap decision kind of based on our gut and our intuition, like you said earlier in the presentation, we can actually make very sound data-based decisions and take action more quickly than we would if we didn't have access to this type of information.
Mm-hmm.
And just for the viewers here, Dave, were you able to see that chart as well? I want to make sure that's coming up for people.
No, I see you.
All right. Well, we'll definitely make sure to get that screenshot up on the board here as well. I've got a team of experts behind me making sure everything runs smoothly. So, but thinking about kind of moving beyond the member experience, wanting to take a few questions now. Now we get to the fun part. I think at this point, everyone, I would invite you to take yourselves off mute and join into the discussion. I know we have a few questions coming in here via Twitter and through email, but before we get to those, I want to open it up to anyone that might have a question directly for Dave.
What would you say is the hardest part of convincing not just the board of trustees, but the individual risk pool member groups to the strategy of looking at data in a different way? And what do you think was the hardest part for them? I know you talked about them not just knowing that it even existed, but once they kind of knew that it existed, wasn't there still sort of some delay as far as their ability to kind of jump on board to this idea?
Well, I think there are probably two parts to that. From my perspective, at least in our experience here, I think there was a sort of a preconceived notion that whatever the carrier was providing them, they must be the experts, and therefore what they're providing us must be what we need to see. So again, I mean, showing them the ECR and the claims is like, well, that must be what we're supposed to be looking at. So I think the full-blown data pull we did, along with the data, and again, I don't remember how many hundreds of pages it was, but I think having someone to help interpret the story that data tells was absolutely critical. I mean, to give them that data, they'd look at it and say, okay, but I don't know what this means. I mean, what are you telling me? So I think I would hate to use the term dumb it down, but to sort of put it in layman's terms, because remember, these people are just trying to do the right thing. They're presumably representing their group. The question is, so what story is this telling me? And what should I do? I recall the, sort of the 4 buckets of, the healthy, the at-risk, the chronics, and the acutes, and saying, having an approach. Now, that's a pretty basic look, but looking at them and saying, we have to have different strategies for these. And do you understand that people migrate, towards a more unhealthy state? I think resonated with them. So I think getting away from the insurance speak and getting them to understand conceptually what people are trying to accomplish, I think was a huge first step. And I think sometimes they're looking for a silver bullet, like magically you're going to wave this wand and everything's going to change. So I think bringing them along in that journey in sort of what I'd call layman's terms was really helpful for them. And I think what it did is prompt more questions, because I think they kind of looked around the room at each other like, I don't want to ask this question because I don't want to look stupid, but I wonder about this. And I think it opened the door to have that conversation about what are the drivers. And I think acknowledging that there are going to be accidents, and there's, someone's going to be in a car accident, and someone out of the blue is going to, have a heart attack or, need transplant, God knows whatever it is, but to help them sort of compartmentalize there and say, well, what do we know we're going to have in experience in this size population? But what are the things we can do on sort of a preventative basis? Getting down to, a heart attack, saying, do you want to replace the engine or replace the oil? I mean, using some of those really kind of hokey basic analogies, I think help them get closer to what it is we're trying to achieve. But I think first and foremost in that discussion, I mentioned it earlier, our understanding at that level that we might be buying this on a group basis, but all those decisions are made individually, that was huge. To say, everybody's making this decision at home. Everybody's deciding when they go in for care, when they don't, what deductible they pick. I recall, again, I'm kind of bouncing around, but I recall one of the aha moments when they said, do you understand that all the sick people are picking the low deductible plan? Do you understand that they've already decided they know they're going to have claims? And so at the kitchen table, they did the math and say, we're going to take the low deductible. I think that was an aha moment for them to say, oh, so all the healthy people are taking the high deductible. Oh, maybe that means our premium rates that we're trying to set internally are a bit out of whack. So I think each of those steps, I think the other thing we learned was this is a subject that is this big. And the idea that this is far too daunting, there are too many stakeholders, we can't possibly get everybody to agree. I think breaking it down into pieces and saying, let's take this a chunk at a time, I think was also really, really good for them to say, oh, I see. We're not going to try to change the world overnight. We're not going to make the employees have to change their plan design. They've got to want to. How do we get them involved in the discussion? Is that sort of address the question?
Yeah, I think it does. I think the other thing that I want to recall from the experience was the notion that the board of trustees looked at saying, we can't just keep doing the same thing over and over and expecting a different result.
Yep. I think you're exactly right. That whole definition of insanity, right? We keep doing this. We know what the outcome is going to be. Yeah. Are we willing to try something different?
Yeah. And I think the idea of doing it at a risk pool level, at a aggregate level rather than an individual group level, also is a key characteristic of showing if we're all going to be in the same shared risk pool, we then all need to be committed to the types of strategies and programming and data that binds us together.
Yeah. I think we also learned in that process, there were a couple of people that were there that said, I really don't care. I mean, if I just want to know how much my increase is so I can budget for it. And I think it was important to identify those people because, again, in the risk pool, I think we learned we needed people to be sort of like-minded. And when someone said, if it's a 14% increase, I just need to know, and it's out of my hands. And I think over the last 3, 4, 5 years, that evolution has taken place. I don't know that those people are still at the table. And I think everyone else has sort of chipped away at them and said, but we, if you're going to be at the table, you need to care. I mean, we need to take care of this because 7 and 14 and 16 and 8, is not a sustainable long-term model, right? So for whatever that's worth.
Dave, I had a question that came in here. What advice would you give to other pools or employers that are looking to improve how they approach and manage health? Is there anything specific to the types of groups or employees that the NGPA services that you think would be helpful to approach in a particular way?
Here's where I think, I know from our perspective, we had some people that said, would you be interested in reducing the cost of healthcare? Who isn't going to say yes, right? I mean, every prospect in the world said, of course, if you've got a better mousetrap, right, what is it? And I think leading them to, well, of course we want to do that, but there are a lot of moving parts. Which ones can you address? What does the blueprint look like? I think the realization that this is a lot of heavy lifting in a lot of different areas, that there isn't a silver bullet, that somebody didn't come up with some magic formula that said, if you do this one thing, I can save you 13%. I think they've all heard that before, right? What makes you smarter than everybody else? So I think the idea on the front end about what are you trying to accomplish? What do you know about your population? How do you get along with that population? Is it adversarial? I know that there have been groups out there that the employees are saying they keep cost shifting to us. We're open to an alternative plan design. Well, if you're only talking to the plan sponsor, they're going to say, well, the union's decided X, right? We got to replicate the benefit and we're on a train we can't change course on. So I think in engaging some of those employee populations, I think here at NJPA, even though we're a very small group, we're 100 lives maybe, that was real interesting when the benefits, the personnel committee who's represented by all the departments got together and said, what would a blank slate look like? Would you be open to that? I think leadership was surprised that they were saying, we're willing to look at something new, right? And I think missing that, I think understanding, are you going to shove this down my throat or do you want to engage us? And are you willing to share in the risk? Are you willing to look at something new? I think those employee groups were more ripe than anybody imagined. And I think early on engaging those people, because we know so much of this has been adversarial, right? Hey, cost went up. We're going to have to raise your deductible. Your premium went up. That's the way it is. Rather than together, can we find a better way to solve this problem? And maybe that sounds too fluffy or too cliche, but I think that's basic sales. Engaging the audience and saying, because what I learned through this from the outside looking in was one of those stakeholder constituent groups can blow the whole deal, right? If one person says no, right, then we're in an impasse. So with all those people, to get them to all pull the same direction, you have to engage them in the conversation.
Absolutely. And you know what? I think that's a great note to end on, is making sure that you engage the right parties at the right time, and making sure that everyone comes to the table with with an open mind. So we're going to wrap things up. That's kind of all we have time for today. But thank you again to our special guest, Dave Doon from the NJPA, and all of you joining us today on Benovate Explores. Make sure you join us next month, March 21st, 11:30 a.m. for our next episode. If you have any feedback or additional questions or comments, make sure to keep in touch. You can tweet at us at Benovate. We'd love to hear from you. Thanks again, everybody. We'll talk to you next month.